And then let me introduce today, we have today Dr. Jones and Dr. Washofsky, who's going to, did I say Washofsky. And we are going to discuss the article on the use of Lactobacillus and placebo for acute gastroenteritis, a practice we've been doing lately. So let me welcome everybody, and I hope you enjoyed the pizza.
And we don't have any relevant financial disclosures for today. So as part of our objectives for today, we'll practice formulating a specific clinical question and understand the study design most likely to yield valid information about therapeutic questions using the PICO-TT format. We'll appraise the article and understand the uses and limitations of a therapeutic trial with the help of the critical appraisal tool format for randomized control trials. We'll discuss and contextualize the concepts of enrichment design as well as intention-to-treat principles and as-treat principles, and then distinguish important factors in the determination of the internal validity of the randomized control study, and then determine the external validity of the article and its applicability in our clinical practice. So when we started looking for articles for this month's journal club, we started thinking about things that patients often ask us for that we don't necessarily have good proof or data as to whether or not it does anything. Like, how many times have you been asked for methadone drops without any real strong belief that they're going to help, but we feel like they don't hurt, so we just go ahead. So that's kind of how we came to this article. Probiotics currently are one of those new kind of hot remedies that parents are requesting for their children, especially when they're getting sick with GI bugs. So why exactly is this important anyway? Overall, gastroenteritis is the second leading cause of death in children less than 5 years old worldwide. In the U.S. alone, there's 1.7 million ED visits per year and 70,000 hospitalizations in children per year. So the costs are not just medical. There's a large non-medical cost to this, including lost earnings for caregivers. So what do we already know about it? There have been prior studies on this topic. Meta-analyses have been completed in both pediatrics and Cochrane Review and have suggested that probiotics work through a host immune modulation, among other mechanisms. But what these studies don't recognize or are not as strong as there are several limitations. So they've had small sample size, lack of quality control of the probiotics, attrition bias, unclear randomization strategies, and then inadequate concealment of the treatment assignments. And then few of the studies included in these reviews actually included the ambulatory pediatric population. So despite all of this, probiotic use continues to grow, especially in the setting of acute gastroenteritis, and it's estimated to be a $67 billion industry by 2023. So we should know who we're giving our money to. So in terms of the clinical question, population, we're looking at children with acute gastroenteritis. The intervention was Lactobacillus. Do you want to ask me the second part? A comparison is the placebo group, and then the outcomes, you have reduction in duration, severity, and complications from acute gastroenteritis. The type of question that we're looking at is a therapeutic question, and of course the study that we're looking at is a randomized control study. So in terms of the study design, the study included children from 3 months old to 4 years old that were diagnosed with acute gastroenteritis. Specifically, to have that diagnosis, they had to have 3 or more episodes of watery stools per day. They could or could not have vomiting, and then they sometimes had to last fewer than 7 days. There were several exclusion criteria for children in the study. So children with risk factors for bacteremia were excluded. That included if they were immunocompromised, if they had used steroids, systemic steroids in the last 6 months, if they had an indwelling catheter, no structural heart disease, or history of prematurity in children that were less than 6 months old. Understandably, pre-existing GI disorders like inflammatory bowel disease were also excluded. If they came in and also had pancreatitis, bilious emesis, or hematochezia at the time of presentation, they were excluded. Naturally, if they were allergic to the treatment, they were excluded. And then the allergies to clindamycin, erythromycin, and beta-lactam antibiotic agents were excluded, with concern that if the lactobacillus caused an invasive infection in these children, that those would be the antibiotics needed to treat them, so they didn't want to include them. And then if their caregiver did not speak at least English or Spanish, they were excluded. So randomization was done with a web-based system. They did stratify according to the size and duration of symptoms, meaning less than or greater than 48 hours. The first dose of either the treatment or placebo was given in the ED, and they were very specific in how they prepared the dose to try and mask it and make everything similar. So whether they got the probiotic or the placebo, it was emptied into 20 mLs of liquid at room temperature, same bacteria per dose, and then oral and written instructions were given to the parents to do twice a day for 5 days. So they made sure that the treatment and the placebo were identical in taste, texture, and appearance. If the patient vomited within the first 15 minutes of getting either the treatment or the placebo, the dose was repeated once. And then providers and patient caregivers were not aware of what group the patients were in. So this kind of goes over a little bit of the exclusion-inclusion criteria. So you can see when they started that they had 3,143 children who met criteria. A lot were excluded, but they did end up with a total number of 971 that underwent randomization. So a pretty good number of patients participated. In terms of splitting between the treatment and the placebo group, they were fairly evenly split, with 483 in the treatment group and 488 in the placebo group. Similarly, we don't know exactly why these children were left to follow up, but they had similar follow-up loss rates, so 15 in treatment and then 13 in placebo. So overall, you had 468 on the treatment arm included in the primary analysis, and then 475. In terms of the patient characteristics, this is a big table. It actually takes up several slides. The overall theme of the table is that the treatment groups were pretty similar, with the exception of racial or ethnic category, and that's just because some of the ethnicities had such small numbers to it that it made it look slightly more significant, I think, played a role in that. But otherwise, in terms of age, sex, and then the reported, again, the table takes up several slides. So you can see the modified Vesicaria scores, which we'll talk about in a second here. And as you go down, there is similar severity in those scores. And again, other presenting characteristics were very similar in terms of whether they had fever, whether they were dehydrated, and then what kind of results in terms of their stool samples they had. So in terms of looking at follow-up for these kids, the parents were asked to complete a daily symptom diary. The data was collected either by phone or email for 5 days or until the symptoms resolved. They got in contact with the parents again at 14 days, and then at 1 month. At 1 month, they only asked for adverse effects. Chart review was performed on all of these cases to make sure that any adverse events that the parents didn't report were caught. And then stool samples were collected for the testing of enteric pathogens, and the Lactobacillus itself was tested every 6 to 9 months for quality and presence of contaminants. So in terms of the outcomes that we were looking at, the presence of moderate to severe gastroenteritis and whether using probiotics during acute gastroenteritis had any effect on that. So they used the Vesicaria scale, which again we'll go over in a second, but a score of greater than 9 on the Vesicaria scale during the 14 days post-enrollment was considered significant. Just as a note, if the patient stopped with their vomiting and or diarrhea for 24 hours, symptoms after that time point weren't included. It was counted as a separate illness. The highest scores for the 7 variables in that table were summed on the last day first. So this is the Vesicaria scale. As you can see, there are 7 different components to it. So the duration of diarrhea, how many watery stools they were having per day, duration of vomiting, again, maximum number of vomiting episodes for 24 hours, temperature, whether they had any unscheduled healthcare visits, and then treatment. No points if they did not need any, if they needed rehydration, hospitalization, and then there's nothing more than hospitalization that would get them extra points. The scores overall range from 9 to 20, with higher scores indicating more severe disease, and this is a validated tool for use in pediatric patients and EDs in North America. So in terms of the secondary outcomes, so they looked at what you would want to know with a kid for acute gastroenteritis. How often and how long are they having diarrhea and vomiting? How many healthcare visits did it take? how many days were they out of daycare? How many days did their parents or caregivers have to miss work? How many people in the household got sick, because that's always a popular one with siblings. And then safety outcomes. So were there any extraintestinal infections, any side effects, and any adverse events? The number of health visits, just to clarify, was within the 2 weeks of the index visit. And then rate of household transmission was only if the household members were asymptomatic at time that the patient presented, and then if they developed symptoms after that point.
So, as far as statistical analysis, they used an intention-to-treat analysis for the primary outcome with kind of the exception of side effects, which was performed as treated. So in an intention-to-treat method, that's looking at, in a randomized study, all participants who are randomized are included in the statistical analysis and analyzed according to the group that they were originally assigned. So regardless of what ended up actually happening, if they got the treatment or not, if they were put into the treatment group, they were analyzed in that group. In an as-treated study, you're looking at participants based on the treatment that they received, and it doesn't necessarily take into account the group that they were actually randomized. So they wanted to look at using an as-treated analysis to provide additional insight in the event that parents weren't actually giving the probiotic or the placebo to the child as they were supposed to, which would result in an underestimation of the treatment effect. So they looked at both primary and secondary outcomes using two different types of tests. One is called the Mantel Haenszel test, and essentially these are two, and then the other is the Elteren modification of the Mann Whitney test. So these are two different types of comparisons and looking at outcomes. So in the Mantel Haenszel test, you're looking at categorical variables. So you've got your placebo group versus your treatment group compared to categorical outcomes. And primarily they were looking at yes or no to severe gastroenteritis or moderate to severe gastroenteritis. And then they were looking there to see if those two, if we were seeing a significant difference between the two. Interestingly, both of these types of tests do not assume a normal Bell's distribution, and it does kind of allow a more accurate approach to kind of look at the different variables. Mann Whitney, in comparison, is looking at a comparison of a categorical variable to a continuous outcome. So looking at temperature, looking not fever yes or no, but the continuous variable of temperature. Looking at the continuous variable of this scale, the Vesicari scale. And then because we were looking at so many different comparisons, essentially when you have the more comparisons that you investigate, the higher risk or the more likely you are to have significance due to random chance or error. And so this Holmes procedure was used to adjust significant levels to minimize significance due to chance, which helps to make the data more reliable and more robust. And then they used software from University of Michigan and SAS. So this is their results. So you can look kind of from the get-go and see that all the p-values here are above 0.05, except for this 0.03, which is looking at repeat healthcare visits. However, when they used this Holmes procedure, the actual p-value that they were using was 0.008, so this actually is not considered significant. So the outcomes that they found, both looking at primary and secondary outcomes, were all insignificant comparing the two groups between placebo and treatment. And then, so looking at this here just shows it's taking kind of your mean number of episodes of diarrhea per day versus your mean number of episodes of vomiting per day. So these are looking at secondary outcomes. You can see that you've got the numbers as they go down from day 0 from when they initially sought care to day 14. And the difference between the two groups, placebo being in the blue and Lactobacillus being in the red, are very, very similar. And these are the 95% confidence intervals here, and they're very similar themselves. So this is just showing how similar the data really was. So just kind of breaking it down a little bit, if you look at the post-enrollment modified Vesicari score, so they're looking for a score greater than 9. This was seen in about 12% of patients for both groups. So 11.8%, 55 participants out of the 468 in the treatment group, and 60 of the 475 participants in the placebo group. And this had a relative risk of 0.96 with a 95% confidence interval that did not include one, or did include one, sorry. So this was not considered significant. And then looking at secondary outcomes, there really was no significant difference in groups in terms of all of the different things that we were looking at. So frequency, duration of diarrhea and vomiting, the proportion of unscheduled healthcare visits, days of daycare missed, hours of work missed, rates of household transmissions, or in adverse side effects. They did find in five cases in the treatment group an increase in wheezing. Whether or not that was related is yet to, we don't know, but that was the only kind of difference that was seen. So the study conclusion was that a 5-day course of Lactobacillus did not result in a lower number of moderate to severe cases of gastroenteritis.
So looking first at whether or not the results of the trial are valid. So was the assignment of patients to treatment randomized? Yes, they said up front that they used a web-based system that was used to randomize the patients, and then the randomization was further stratified according to size and duration of symptoms. They did use a block randomization. This helps decrease the opportunity for bias and confounding by having the treatment groups that are random samples of the population sample. So it's a very good practice for randomization. Were the groups similar at the start of the trial? Again, yes, overall similar in groups except ethnicity. When they did compare the groups, they used Kruskal-Wallis, which Carol spoke about, and there was a p-value of 0.083, meaning there was, 0.02. So there was some significance in the difference between those groups there. So aside from the allocated treatment, were the groups treated equally? For the most part, yes. Stool testing was completed. The education that the parents received was the same. That being said, with a trial of this size, you can't really account for the institutional differences in the care given and the size and number of institutions involved in the study. And then they didn't really mention any of the adjunct treatments. Did they get Zofran? Did they get Imodium? Were some of them on a keto diet? Were some of them, how did their diet affect what they're doing? And then hydration differences. And then were all the patients who entered the trial accounted for? As we noted before, there was some loss to follow-up and some withdrawals from the study for various reasons. The number between the two groups was very similar. There's also a large amount of exclusion criteria that was taken care of up front. We only had about 2 to 3% loss in each group. And were they analyzed in the groups to which they were randomized? So yes and no. So again, it's an intention-to-treat analysis. So with the exception of side effects, which was performed, that analysis was performed in the untreated population. They were analyzed in the groups in which they were randomized. And then were the measures objective? So again, yes and no. Duration of symptoms, number of missed days. These are somewhat objective measures. The Vesicari scale helps to put a objective measurement on symptom reporting, but symptom reporting, there's always a certain amount of subjectivity that goes with that. And then where the clinicians kept line to which treatment was being received. So again, they took great effort to make sure that both the treatment arm and the placebo, the products used were identical in taste, color, texture, and smell. And so the clinicians were not told which they were receiving. All right, so
how large was the treatment effect? So this study used a lot of different comparisons, different odds ratios, and that there was no significance in any, or no significant difference between the groups. So therefore, we determined that this was a small treatment effect. It really wasn't making a difference one way or the other. So how precise was the estimate of the treatment effect? So the confidence intervals given, depending on what they were looking at, we had, so for confidence intervals for the various means that were compared did cross 1, so those were therefore considered insignificant. And you can see there the confidence interval does cross 1. In looking at the modified Bezikari scale, they used ratios, and that confidence interval did not cross 0, therefore was also considered insignificant.
That's actually not right? So the means are the differences, right? And 0 is what is 1 mean minus 1 mean, right? The ratios is 1, and in this case, they put like one of the mean outcome that you see was a relative risk. That's the one that crosses 0 is a relative risk, and that was the difference between moderate to severe episodes of acute gastroenteritis. That's the ratio there. So if you look at the tables, all the tables were ratios, and those are all passing through 1, so there's no significance. And then on your scale that you have the means, that's when you see the differences, and you see all the confidence intervals that are interlapping to each other. That's the one that should be 0. Just so, because you use mean and risk bad words somehow.
Okay.
Just now, just so it's clear. Is everybody following me what I'm saying?
Okay. Sorry. So essentially, this was showing that the data was precise. However, it remained inconsistent. And then this was just showing again how the confidence intervals did not or overlapped completely, pretty much for all of the.
So just go back to that one, just to show, right? So you have a difference, you have a mean, and you have a difference. So you basically take one value minus another value. So just look at this one. You take this value minus this value. If that is really crossing through because it's 1 minus 1, if it goes by 0, then it's not significant. All these confidence intervals are really interlapping each other, where probably they all have very similar values, and that's why when you do one mean minus another mean, that was insignificant. While if you show the ratios on the other with the big table, then you have a relative risk, and one relative risk or one risk over another risk, then 1 will be the value, okay? And if this confidence interval pass through 1, like the first slide that they show, then it's when it's not significant. I just want to make sure you don't get confused on that.
So will the results help me for my patients? Are my patients similar enough to those in the study? Yes. So we have similar age groups, similar demographics. While this is probably generalizable to the U.S., it's not necessarily true in other countries where rotavirus, other causes of diarrhea would be more prevalent. And then it would be effective in kind of a rotavirus, acute gastro, as some studies have shown. It's hard to say these kids are more likely than not have been vaccinated. So is this treatment feasible in my setting? Yes. Or are you doing it? There was no difference, so the larger obstacle may be just getting parents to buy into the idea that it's not going to make any difference. But there's really no clear positive effect or really potential for side effects either, so is it really doing any harm either? And then will the potential benefits of treatment outweigh the potential harms of treatment? for my patients, no, there were no clear harm or benefit to the treatment. There are possible side effects, but, those few that had wheezing, was that really from the probiotic, or were those kids more prone to wheezing? We don't know. They didn't speak to that. So it was a small number. And so our conclusions, there's really no clear indication for the standard use of probiotics in the treatment of acute gastroenteritis, and really we need more research to be done as we learn more about the effect of individual microbiomes and the efficacy of such treatment.
Yes, great. I really like clinical questions like that because they're going to come up a lot. I did have two things about the topic or the particular study that kind of bothered me. One, and you guys mentioned it, they didn't account for diet. So it's possible that some of these kids were, eating yogurt with live cultures in them and other things like that could have confounded things. The other thing is on the modified Issaquah scale, they mentioned that temperature, they adjusted for how it was obtained. So for axillary, they added a degree, and for oral, they added 0.6. And I wonder if they went back and looked at that and just treated all temperatures equally, if that would have moved some kids out of that, if they were really stratifying kids as moderate and severe when actually they weren't moderate or severe. So.
Yeah, and that's a good point. They did not speak to how many there were that they actually had to use that. So I don't know if it was the vast majority they had to adjust versus if it was just a couple.
Right.
But that is a good point. Another thing that I found interesting too that I didn't mention, but that I thought was interesting, they did not exclude patients that were already on antibiotics. So if a child had gastro, was on antibiotics already, they were treated the same, and that to me doesn't make a whole lot of sense, just thinking of in terms of what antibiotics we know do to the gut, and then why we give probiotics to children who are on antibiotics, which is a whole different kind of conundrum.
Two thoughts. One, I believe, I'm going to use a brand name, but I believe this is Culture Health,
Yes.
right? So it's my understanding that there are other products out there. So I've heard Dr. Hart talk enough that different products have different bacteria. They may have different results. So this may not be generalizable across the board.
Right.
That's a thought. The other thing that you mentioned, and we often say this, that, well, it doesn't hurt. But it doesn't help either, and, I just looked at the price. I mean, this is not necessarily cheap, right? And so, we're tasked with the cost of healthcare. We get blamed for it all the time. And this is just yet another example of something that, this is pretty good data, I think, that says it doesn't do much. But, we all want, and parents want to do something, right? Even though something sometimes hurts and sometimes doesn't help.
I was curious as to why they only chose 3 months to 4 years of age, and did they stratify across age groups? I mean, I feel like the microbiome of 3 months old is different than a 4-year-old.
We wanted to look at kids under the age of 5 because those are the ones that are at highest risk of dying as a result of this, of gastroenteritis. I'm not entirely sure. I don't think they stratified by age, and I'm not sure why they picked 3 months as the youngest either. They didn't necessarily say.
Question. Can we go back to the trial outcome table on page 2010? Okay. So, as I read the article, I think what the team is saying is that they really didn't notice both a difference in the numbers, in like the outcome numbers between the treatment group and the placebo group. So the first column of results for the treatment group and the second column of results for the placebo group, that the numbers were about the same. And then is the p-value supposed to be the likelihood that this is by chance? And therefore, because the p-values were weren't significant. This was part of the conclusion that that there was no difference in the outcome. So the fact that interpretation of the p-values is either significant or not significant, is that part of how the study group came to their conclusions about the effectiveness of the treatment?
Yes, saying that there's no difference between the two groups.
Right, okay. So then the point that I would like to make is that more than half of the eligible study enrollees chose not to enroll in the study. And so when we had a similar discussion about another journal article recently, that a huge number of potential patients to be enrolled in the study participants chose not to enroll. And so although I think this study is really interesting because it has big numbers, if we had enrolled another 100% study participants, I wonder if we would have actually seen some statistically significant values and gotten some different numbers. Dr. Jaimes, do you feel like adding more, you doubled the study size? Do you think that we would be changing some of those p-values and therefore the outcome of the study?
I'm not so sure of that. So what they did to calculate the amount of patients they wanted to have, they used a treatment effect of 10%.
Okay.
I think that would be different if they had used a treatment effect of like 3% or 5%. So if the treatment effect is less, but they consider based on their, plausibility or biological reasons why, what is significant clinically, that 10% was a clinical significant difference, and that's why they use it. They also did something and they give a power 90%. So usually you use 80% power, which means that they have less possibility of finding less non-effects secondary to having low power. So the power they used was actually 90%, which means that they have less possibility of showing no effect when it was actually. So I think they actually make the power kind of higher than usual to be able to find effect. So I'm not sure that the number of patients would have made a much a difference really in this specific group. But I think, and then if you look at the table before this one, that has, I think it's possible that the reasons why, in my brain, obviously Dr. Hart has a better brain than that. I feel like the possibility of the reasons why, the reasons why they have the diarrhea could have made a better effect of having the probiotics. Like we do this all the time. Every time we give them antibiotics, we tell the parents to give it with yogurt or give them probiotics to help because we know we're killing all their bacteria in their body. We want to keep some good bacteria in their body, and it helps. We've seen that, right? So there might be one of those distributions of those different viruses and bacteria and potential parasites and that could have been or could be potentially better served by giving probiotics. I think that's a possibility. And in this study specifically, and the meta-analysis before, rotavirus was huge on the proportion of patients sick. And in this study, rotavirus is only 15 and 19. So overall, only really comparing to the majority of them, it was all the reasons. So they didn't specifically do a separate analysis for that, but in other studies, the proportion of kids having diarrhea with rotavirus was higher. So maybe I think more the etiology could be related with. And then he has a big point, right? They excluded people who had had probiotics 2 weeks before, but they didn't exclude people who had had antibiotics. And they did not exclude people who take yogurt. And they take yogurt all the time. It's part of staple diet for many, many Americans. So we didn't really control anything for diet. And that could be a big thing here that could modify the outcome, because when we do one of these questions, go back on the analysis, right? When we talk about whether they treat differently, or not, we say if there was any difference between the treatment between the placebo group and the treatment group. There was nothing mentioned about the diet. There was nothing mentioned about the way you hydrate the kid. It was nothing mentioned about whether they had yogurt or didn't have yogurt. And that could all be, affecting the treatment effect. So it's possible that all those kids that were not were having placebo were having yogurt. It's very possible, and they did not control about it. So the next one. Or so that is one big thing that they did not control about it. So when you're comparing two treatment effects, it's the third question is the internal validity. The third question of the internal validity. Where the patients are allocated just participants in the study. 1, 2, 3. So this is the big difference, right? Because they did not mention anything about it. So it's like they could all have been, all the placebo kids could have having yogurt once or twice a day. So they were also having probiotics. So that's a big need in the echo. So they could have, say, limited or account for it, but I guess for seeing the treatment effect, they would have to limit it. So that's on that. Anybody has anything I didn't say that was clear? I said that you want me to explain better of all I say? Sorry.